The MGS Diapason modular revision system for uncemented implants has been designed for precise and easy treatment of revision cases or primary cases for particular anatomical conditions. The implant system is entirely made in a titanium aluminium vanadium alloy and includes 13 distal components, subdivided into 3 lengths, 130, 160 and 210 millimeters, and 5 diameters, from 14 to 22 with a 2 millimeter progression, and 8 proximal components, available in 2 sizes of 4 different lengths each, from 65 to 95 millimeters at rotation center with medium articular head. The system also includes a locking screw and a closure plug contained in the proximal component sterile kit. The distal component is tapered, straight, and has 8 longitudinal fins and a nose-shaped tip with tuning fork diapason flute, which, if correctly positioned, provides maximal distal stem elasticity following the anatomical shape of the femur. The whole surface is corundum finished for optimal surface roughness. Similarly, the proximal component surface is corundum finished except for the implant neck, which is polished. The cervicodiaphysial angle is 130 degrees. Along the anatomical axis, on the anterior-posterior surface, there are 2 anti-rotation shoulders. A rib with 2 through holes in the trochanteric area has been designed for bone circlage wiring and muscular tendinous reinsertions. The universal taper coupling has been designed to assemble any proximal component with any distal component. Coupling options are suggested by the manufacturer for optimal compliance with mechanical, cosmetic, and radiographic requirements. A total of 64 different solutions can be obtained with a length range between 195 and 305 millimeters. The rigid reamers are used to create the canal for the distal component. Each stem has a dedicated reamer. The reamer shaft is provided with depth landmarks corresponding to the rotation centers of a medium-size head. The T-shaped handpiece is provided with a Harris connection and is used in combination with the reamers for manual preparation of the femoral canal for the distal component. 2 reamer-guided cannulated broaches can be used to create the canal for the proximal part of the revision component. In this way, perfect component alignment can always be obtained. The distal impactor is provided with the same depth landmarks as the reamers, which indicate the correct proximal component size. The proximal impactor has been designed to allow effective and stable coupling of the 2 implant components. The impactor is directly fastened to the proximal component. This little graduated instrument can be used for different purposes. The most important is to check correct taper coupling of stem and proximal component. The instrument is provided with the same depth landmarks to be found on the reamers and the distal impactor. Trial components have been developed to check femoral anteversion and retroversion, muscular tension, and total leg length. The landmark on the trial component is located in the same position as in the final component. The counter-torque handpiece is used to compensate for torsional stress generated by locking screw and closure plug fastening and prevent stress transmission to the stem. Trial heads with a 28 mm external diameter are available in 5 sizes and with a 32 mm external diameter in 4 sizes. This instrument, called separator, is used in combination with the proximal impactor to release the taper coupling and remove the proximal component without affecting the original position of the distal component. The reamer rack is equipped with a safety system to prevent accidental closure and for personnel protection. Pre-operative planning is necessary in each individual case to determine the size of different implant components and especially distal component size. It is advisable to plan the use of a proximal component size 2 or 3 with respect to the rotation center to be obtained and the femoral canal diameter. Then, choose the most suitable distal component size to obtain optimal stem stability. Remove the stem to be replaced and expose metaphysis and intramedullary cavity. Remove bone cement residues and granulation tissue. Using the reamers of length established during preoperative planning, perform manual reaming of intramedullary cavity, checking alignment with anatomical axis. Prepare the cavity by increasing reamer diameter 2 mm at a time and keeping the same reamer size. Correct reamer size can be established by introducing reamer until reaching position between notch 2 and 3 and checking femur engagement in reamer rotation. The hip joint rotation center is generally located on a tangent line to the greater trochanter tip and perpendicular to the anatomical axis of the femur. Reamers are provided with reference landmarks to enable identification of this line as well as of the implant head rotation center. If the proximal metaphysis is very damaged by bone resorption, it may not be necessary to use the broaches for proximal component canal preparation. The metaphysis is prepared using the dedicated broaches, guided by the borer shaft, to guarantee perfect alignment of the two components. Broach penetration depth can be checked through a hole by looking at the reference line marked on the broach handle. Penetration depth is correct when the reference line on the broach corresponds to the line on the reamer aligned with the greater trochanter tip. During this phase, check broach rotation angle based on neck anti-retroversion angle to be obtained. As indicated in the SAMO component compatibility table, based on reamer diameter, one can decide whether to use only the broach indicated with the letter A or to complete the preparation of the metaphysis by using the broach indicated with letter B. Broach depth must be always in compliance with the chosen reference landmark, especially in primary cases when good stem fit must be obtained in combination with contact with metaphyseal cancellous bone and good calcar support. Remove reamer and insert distal component. Assemble distal component taper coupling onto graduated impactor and make sure that tuning fork-shaped flute is located on reference line marked longitudinally on impactor. By using the screwdriver, attach the impactor to the distal component by tightening the screw contained in the instrument. Therefore, during distal component introduction into the canal, the surgeon, while being unable to see the implant tip, can still place the tuning fork in the correct position, that is, with a slot parallel to the patient's frontal plane. The impactor has the same reference lines as the reamers to indicate the size of the trial component for joint reduction test. As you can see, it is advisable to correctly position the implant in the femoral canal from the very beginning. Use the impactor to introduce the implant until it would not go any further. As you can see, implant position is the same as the last reamer used. In this case, the reference lines on the impactor indicate a proximal component size number 2. Remove impactor with screwdriver. Place size 2 trial component onto distal component and use inner screw to fix it to the prosthesis in the correct anti-retroversion position. Torsional stress generated during screw fastening is contrasted by using the counter-torque handle. In this way, stress is not transmitted to the stem and incorrect proximal component positioning is prevented. Place selected trial head onto the taper. As to be expected, the trial head rotation center is aligned with the greater trochanter tip, which has so far been used as a reference guidance. If joint reduction test is satisfactory, mark the bone where indicated by one of the 2 reference lines on the component. This additional indication helps introducing final implant in the same position established during joint reduction test. Remove trial component and remember contrasting torsional stress. Fasten impactor to proximal component. Accurately clean and dry the taper of the distal component of the prosthesis to prevent debris from femoral canal preparation from hindering correct conical coupling of implant components. To introduce final implant in the same position identified with trial reduction, make sure that the implant shoulder coincides with the reference line previously marked on the bone. Introduce proximal component with impactor. Remove impactor. Introduce the graduated rod of multifunctional instrument into implant hole to check correct component coupling. If the reference line located under the size number of the implanted proximal component is located at the same level as the implant shoulder and is completely outside the hole, coupling has been correctly performed. Secure component coupling by means of locking screw. Complete assembly by applying closure plug. Before final joint reduction, perform another reduction test with trial head. Implant selected articular head and proceed to final joint reduction. If implant adjustments are necessary, proximal component can either be removed or positioned in a different way. Closure plug can be readily and easily removed. Removal of universal locking screw may not be equally easy, since it is located completely inside the hole. The problem can be solved by using the multifunctional tool that is provided with a plastic end piece to catch the screw and easily remove it. Accurately fasten proximal impactor to implant. Introduce threaded rod into impactor by fastening it all the way into the instrument. When reaching the bottom of the taper hole, the rod will produce a distraction force separating the two components, as a consequence of the reciprocal movement of impactor and threaded rod. The proximal component can now rotate freely, and the surgeon can correct anti-retroversion and introduce implant with impactor again, without having to remove the component from the canal. For proximal component replacement, go through the previously described surgical steps and make sure that coupling tapers are always clean. After every adjustment, check taper coupling of components. After making sure that all components have been correctly positioned, reintroduce locking screw and closure plug. For stem extraction, remove closure plug and locking screw first. Fasten the extractor onto the proximal component and proceed with stem extraction. Applied force and generated vibrations can help release only the proximal end of the stem. In this case, fasten the extractor onto the dedicated auxiliary end piece in order to safely engage the component still in place and remove it. Before cleaning the instruments, remove the inner screw from the distal component impactor by simply pushing it with a screwdriver. Trial components too have to be disassembled by using the multifunctional tool to remove the counterclockwise bushing placed at the proximal end. In this way, the locking screw can be removed and the instrument can be completely cleaned. It is advisable to always disassemble trial components. Failure to clean them or incorrect cleaning inevitably leads to malfunctioning and waste of time during surgery.